we go. Perfect. All right. Well, my name is Katie Lewis. I'm going to kick us off today. I'm the Director of Marketing Operations here at MiHIN. You've seen me once or twice before. I know I'm not the usual Joanne that kicks us off, but I think Joanne is feeling a little under the weather, so she is still here. I'm sure we'll be active on the chat, as we hope all of you are as well. Please use the chat as you always do, or feel free to come off mute. You should all have that option. To come off on me, as we like to keep these really engaging and have a lot of good discussion. So I don't have too many slides this morning because I really want to just make sure we get right into why we're all here to hear from Megan, but just our standard slide about who MiHIN is in case you are new to the download. So MiHIN is Michigan State Designated Entity to continuously improve healthcare quality, efficiency, and patient safety. So today, like I said, I'm just going to kind of jump right into things because I think we have a really exciting topic to talk about today. So I'm excited to welcome Megan Gibbs, who many of you already know, but for those of you who don't, Megan is our Director of Customer Success. She's here today to talk to us about how MiHIN is working to standardize and make outbound CCDs usable through the emergency medical services use case. And as part of that, I'm going to highlight a collaboration aimed at enabling seamless communication between ambulances and hospitals to eliminate delays and streamline patient handoff. So Megan really is the expert on all of this, so I'll keep my intro short and sweet. But again, please feel free to use the chat to ask any questions you might have along the way. I'm sure I'll stop Megan and have her answer some of those. And then we'll also make sure to leave time at the end to answer anything that we might not have gotten to. But without further ado, I'll pass it over to you, Megan.
Thank you, Katie. Let me go ahead and pull up my slides. Do this here. Man, I will never get used to multiple screens as much as I like to think I'm tech savvy one of these days. All right, let's do,
We can see your slides, it's just not in presentation mode.
I know, I can't figure out. There we go. Okay. Maybe. There we go. All right, so let me move this to the slide. Okay, thank you so much, everyone, for taking time out of your day to join me today. I see some old names on here, which is absolutely fantastic, as well as some new names. So thanks, Katie, for the warm introduction. Today, I want to go through our emergency medical services pilot that the MiHIN team is working on, but more specifically, the overall goal that we're seeking to accomplish is what you see here on the screen, right? Addressing data exchange barriers by utilizing health information exchange. So just a little bit about me. Like Katie said, my name is Megan Gibbs, and I am the Director of Customer Success here at MiHIN. I will have been at MiHIN, I think, over 10 years now. I started my journey here as an intern, and I absolutely loved what I did at the time. I was in the onboarding department. So I helped any organization that was seeking to utilize any of MiHIN services to get up and running. I had a couple of position changes in between those years, and then I came back to the customer success team, I think last March, actually. So it's an entirely new team. We're close to being 2 years old, but it's come full circle. And so I'm really excited to be in this position again, because it also helps me improve the things that we're doing today in terms of onboardings and workflow processes and customer service. And then I also still get to work with a lot of amazing people in our network. So again, thank you so much for taking time out of your day to join us today to hear more about our pilot. Before we begin doing a little bit of deep dive, I would love to level set on some important definitions, because you're going to hear me use various acronyms today. I'm going to try my best not to, but MiHIN speaks in acronym soup. So there's 4 key definitions that I want to share with you all, just to make sure that we all have the same understanding. First and foremost is MiHIN's active care relationship service, also known as ACRES. Our ACRES solution is a key component to how MiHIN does business and how we route data and how we define which patient populations belong with which specific healthcare professionals. So when we talk about acres, we're talking about defining patients and their healthcare relationships with these professionals through the means of attribution files that are submitted to MiHIN. And that data is used for MiHIN to, one, determine the members of your patient population, and then two, we use the delivery preferences to determine how we should route that specific data to the receiving organization. So really simply put, it's the means of healthcare professionals receiving their specific patient's data. So to make sure that they stay in the know and that they can provide better care and treatment to their patient population. Secondly, we have real-time ACRES, or the real-time active care relationship service. So this is kind of a spin-off on ACRES, but what we do here is utilize inbound admission, discharge, transfer notifications, also known as ADT notifications, for MiHIN to establish relationships between a sending source and a patient in real time. So subsequently from that, we're also able to not only establish those real-time relationships, but then we can route data outbound to members of that patient's care team, as well as that sending source, so they remain in the constant know of what that patient is dealing with any sort of healthcare setting that is participating in the network. Then we also have consolidated clinical document architecture, also known as CCDA. And that's more or less your standard for exchanging information from a single patient visit. And then you also have your continuity of care document, which is your CCD. And that's the core data set that is contained within that CCDA. So I think at one time I had someone explain to me, hopefully this is still true, that if you think of a Smarties candy, right, the wrapper to the Smartie is always the same, no matter what Smartie you grab from which bag or from which seller. That's your CCDA standard. But the Smarties within those wrappers are never in the same order. There's never the same amount of color, right? But that would be how you can explain your CCD. So hopefully that helps. But if you have any questions at any time throughout the presentation today, please feel free to utilize the chat, come off mute, happy to engage. So when we start diving in and talking about why MiHIN came up with this EMS pilot use case, this goes back to conversations dating, I think, back to 2017 and 2018. We knew that the EMS agencies and the populations that they served needed to have the healthcare data, but at the time we weren't quite sure how. And now that you've talked about progressing into, towards the tail end of 2024, which is wild, I'm so happy to see that this topic is coming back up again and being discussed. But while we've had these conversations, we've recognized that there are some serious interoperability challenges when you start talking about CCDA specifics. MiHIN does have an ambulatory CCDA use case, and what we found is that there's a serious lack of standardization across the board. It's not easy to map and say the data will always be sent in this specific section, regardless of the sending source that you're talking about. We did a very thorough analysis and put a lot of man hours into this and determined that there wasn't really an easy way to come up with a standard because of how the data was being sent. And that's going to require a lot of really high level conversation and then a little bit of a deeper dive to figure out what that new standard could potentially look like. Furthermore, we also have significant high volumes of ambulatory CCDA data that MiHIN receives. I'll give you some specifics in the next couple of slides, but it also makes it really hard to standardize the content within those ambulatory CCDAs with the high number that we receive. What's the standard for when they're sent? What's the standard for when they're not sent? How does that vary from organization A to organization B? And because of that, right, so the lack of standardization and high volume, you have variations in content. My sending source might put specific information in this specific section, but somebody else might say, we don't put it there, we're going to put it here. So that goes through all the encompassing issues that we're seeing is again tied back up to those interoperability challenges that we're facing day to day. With that, we recognize that there was a problem or there's a gap in this space, right? So fast forward to, I think the conversations had started over a year ago. We recognized that we wanted to find a way to exchange data that specifically focused on emergency medical service or your EMS agencies, hospitals, the broader patient care team, as well as that patient. So Our challenges that we're facing is how do we make sure that the data is exchanged in a timely manner? How do we make sure that the data is accurate and usable? But also, how do we prepare the hospital staff for that patient's transit to that specific hospital, even if they are having an emergency transportation visit? But then you start thinking about the aftermath, right? How do we make sure that we get that information to the member of the patient's care team so they know that that patient is headed to the hospital? And maybe they can call the doctor ahead of time and have those conversations. So given the interoperability challenges and everything that we were kind of really facing, we know that the lack of interoperability, regardless of what you're talking about, creates delays and inefficiencies in sharing patient data, which we're all aware can lead to potential risks and gaps in patient care, especially when you start talking about miscommunication and extended response times. So with the purpose of our EMS pilot, we're hoping to explore additional opportunities and solutions that will bridge the gap in enabling seamless data sharing between the patient, the EMS agency, the hospital, and the members of their care team to ensure and enhance patient outcomes and coordination of care. So kind of mentioned a little bit, right? This is our innovative solution to resolving some of those interoperability challenges. While we do have that ambulatory CCDA use case, we kind of wanted to focus on a specific area to determine how can we make this work here and then maybe create some sort of standard that can be used globally within our use case. With that, we did launch our EMS pilot. And the purpose of this pilot, again, is to be able to streamline data sharing between EMS agencies, the hospitals where they're transporting those patients to, members of the patient's care team, and then getting that information from the hospitals back to the EMS agencies, as well as members of that patient's care team. So everybody in this data exchange has a full comprehensive understanding of what happened at the time that the patient called 911, all the way until they were discharged from the hospital. So as part of our data exchange, we have partnered with Beyond Lucid Technologies, Reading Emergency Unit, and Hillsdale Hospital to work towards standardizing data into a US CDI compliant form, and then being able to enhance the usability of that data across the multiple healthcare settings. So with our pilot, what we're aiming to do is to, again, improve the quality of that patient's care, timeliness of the care through efficient communication, and ensuring that all members of all members of the team that are seeking to provide care to that patient know exactly what is happening at any given time. So just for a little bit of background to set the stage of what kind of drove our work in the EMS space is, you've heard me mention that MiHIN does have a statewide ambulatory use case that we support as part of our statewide network exchange. As of I think maybe a week ago, when I was looking at some data, MiHIN receives inbound ambulatory CCDs from over 500 participating organizations. And they all vary across the healthcare sector. So I saw CCDs from provider organizations, hospitals, cardiology clinics, commercial employers, women's health labs, dermatology clinics, you name it, I saw it. And so when you start thinking about the sheer volume of organizations participating in sending this data, then you start thinking about the lack of standardization, right? The content and how it varies from one sending source to the next, which then poses the problem for everybody that's seeking to participate, let alone receive the data. So to put it in perspective, I have a timeline here. And you'll see back in Q2 of 2023, MiHIN received over 54 million ambulatory CCDAs. Fast forward to almost a year later, we've received over 100 million ambulatory CCDAs in that given time frame. So there is a significant amount of data coming into our network. And when I tell you we put those man hours in to try to standardize the data, boy, did we. But we still have those interoperability challenges that we're hoping to, again, focus on a niche in the EMS space to figure out if we can solve it here, how can we replicate that on a larger and global scale to be able to utilize those ambulatory CCDAs in provider care settings. So with our EMS use case, we want to bring together the EMS agencies, the hospitals that those patients are being transported to, the health systems that those patients are being transported to, members of the patient's care team, but then also making sure that we get the data back where it needs to go. With this specific data exchange solution pilot program, we really want to give hospital staff a heads up of what is happening prior to that patient's arrival. What did the patient say when they called 911? What did the EMS agency, what kind of care did they provide to the patient when they were being transported to that hospital? So if you kind of think about what the process might look like now, that time spent in the ambulance is key. What kind of medications were given to the patient? Did the patient have a pulse? Why is that patient being transported? But how do you get that information to the hospital staff, right? I think we've all probably seen an episode of Grey's Anatomy or ER or something similar, and it's always that call to say, hey, we have a heads up, right? Something's coming in, something super serious. And then you see them walking through the hallway and they're communicating at a fast pace to try and get all the information relayed to the ER staff that they need to. But what if something is missed? What if something's not documented at that time, or somebody says something and they hear differently, right? How can we get that data to the ER staff ahead of time to better prepare for that patient's visit? So we're utilizing this pilot to accelerate that patient care and treatment so that the ER staff knows what happened when the patient was being transported to the hospital, and thereby reducing any errors that can happen, any miscommunication, any discrepancies for medication that was given in the ambulance, and whether the ER staff wants to follow up with a similar drug. But really trying to close that gap in the lack of awareness of that patient's medical history and what's happening during that transition time to the hospital.
Hey, Meg,
For
could I
the
stop you really quick because we have a few things coming in the chat, and I figure this way we can start to address some of them.
Sure
So
thing.
Jim was asking, do these participant orgs push all of their registration info through I'm guessing is that MiHIN?
So I'm so sorry I haven't seen the chat, but I think that's an excellent question. And one of the things that we were trying to identify when we were going through the content of the ambulatory CCDAs is really understanding when those are sent to MiHIN. What is the trigger response from the sending source that says, I'm going to send this specific ambulatory CCDA at this time? And while I don't have the specifics in front of me, I do remember hearing that we couldn't really figure it out and we couldn't standardize it from one or the other. And I remember seeing this in my early onboarding days too, that when you start incorporating various EMRs and their capabilities, is the ambulatory CCDA triggered at the time the patient is discharged? Is it triggered 4 hours, 8 hours later, 24 hours later, sent in a batch? So I think we need to start asking those questions. And one of the things that we're hoping to also ask as part of this pilot is, from the hospital side, what is the trigger response to send that patient's CCD to MiHIN, which we can then route back to the EMS agency to close the loop? I don't know if that necessarily answers your question, but I think, in hindsight, it's like we're still kind of trying to figure that out. And then maybe we can develop some sort of standard in making sure that organizations are sharing the appropriate data at the right time.
Thanks. And then Amy was asking, are home care and hospice agencies included in your data?
That, I think it's a tough one to answer because it depends on how the data is coming into us. So I can go back and check a report too. I think as of right now, I'm not 100% sure. I know that organizations can send through a single feed and they can identify themselves as like a singular entity. So I'm just making this up. If you have a health system that sends CCDs to us, all the senders in that feed might just be that specific health system name, or they might be broken out. I know from the ambulatory side, when those ambulatory CCDs that are sent to MiHIN, I've seen a very standard name. I've seen anything beyond that, even where it's sent using the specific department at an ambulatory clinic that has a facility name. So I think that also ties back to the standard of naming conventions within the CCDA content. How are we going to standardize the facility names coming through? And is everybody going to use that same sort of standardized format? But when you're talking about home care and hospice agencies participating in MiHIN, yes, they are. But if you're speaking specific to the CCDA exchange, I don't believe we're receiving CCDAs inbound to MiHIN from those entities today. But I would be more than happy to double check and then follow up after the meeting today.
Great. And then do you have time for a couple more right now, or do you want to keep going
Yeah,
through the slides? Okay.
absolutely.
Tina was saying one of the issues we have with data coming to us, PCP, from hospitals is that every time someone signs off on something during an ED visit, it generates the documentation and is sent to us. We would like to only see the final documentation, but have been unsuccessful in achieving that. Perhaps this is part of MiHIN's challenge, and MiHIN might be more influential.
I think that's fantastic feedback. And it is something that we could probably start engaging in our network, right? So we know the hospitals are required to send those discharge medication reconciliation CCDs to MiHIN, especially if they're participating in conformance purposes. But now I think maybe that's the time that we can take it one step further. Do we want to receive, the working CCD? Do we want to receive the final CCD? But we all, I think, need to come together and determine what's good for everybody, right? Because we know that, and Tina, I'm sure you're probably aware of this too, what you might want to see is not something the same as somebody else wants to see, right? But how do we combat that as part of a statewide network? So I absolutely think that could be a future conversation, and going towards making sure that the data and the content that you're all receiving is still useful and not information overload at that point.
All right, thank you so much. And then it looks like maybe one last one right now from Mark. Are there issues with certain types of data? Are there restrictions on sharing data about certain issues, particularly around SUD? Have those restrictions impacted your pilot? Any other areas where there are issues sharing data?
Great question. We do require our EMS agencies, of course, I'm going to forget what it is right now that I have to speak on it. There is a form that they need to sign regarding sharing substance abuse information, because we have seen some of the descriptions that come forward from the EMS agencies in those CCDs where, gosh, now I wish I could remember what it was. I do know that I worked with our legal team to put this form together, and I can share that after call or even after the presentation today. It's probably only going to take me 30 seconds to go look at it, but it's basically a formal agreement that says, we understand that there are specifics and concerns about 42 CFR, but we will be sharing the specific data. So more to come on that.
Great. And then, sorry, there's a few more still coming in. How about we go through a couple more slides as I kind of keep an eye on the chat, and then we'll take another pause to start going through a few more, but I don't want to miss some of your slides.
Sure thing. Thanks, Katie. Excellent question so far. Okay, so given our response to the interoperability challenges, right, I think I've probably explained pretty explicitly what the pilot is and our purpose of this pilot, but what is our end goal? MiHIN's end goal is to connect all 162 EMS agencies to our network. We want those agencies to receive the CCDs from the hospital following that patient's discharge. We want to get the data from those EMS agencies while the patients are being transported to the specific hospitals. We really want to make sure that we have that statewide participation, therefore resulting in the statewide data exchange, to make sure that all we're doing at any point in time is enhancing patient care, improving coordination, and closing those gaps between various healthcare entities and agencies that are trying to provide care at that patient at any given time. So more specifically within this pilot, we, like you heard me mention before, we did partner with Reading Emergency Unit and Beyond Lucid Technologies in Hillsdale Hospital. So just a little bit more about them. Reading Emergency Unit is an EMS agency that is based in Hillsdale County, and they handle approximately 1,600 patient transports per year. So when you start, if you're familiar with Michigan's geography and our counties, it's not a super highly populated county, maybe like Metro Detroit area, but still, when you think about 1,600 patients that being transported to the hospital a year, that's 1,600 opportunities to improve patient care and communication. Reading Emergency Unit is an and I'll kind of go into this a little bit more detail, but they are contracted and located in Hillsdale County, which on my next slide, you'll hear more about Hillsdale Hospital. The Reading Emergency Unit will be sending what I'm calling those ambulatory CCDAs to Beyond Lucid Technologies. Beyond Lucid Technologies is a technology vendor that we partnered with as part of this pilot process, and they're going to receive those ambulatory CCDs from Reading Emergency Unit and then forward that information on to MiHIN. So Beyond Lucid Technologies has nationwide expertise in real-time data extraction, transformation, all things related to getting data out of the EMS agencies and where it needs to go. So they're very familiar with the specific work effort. I know that they're doing similar work, if not the same work in other states as well. So it's a great opportunity for us to work with both Reading as well as Beyond Lucid Technologies. You're all pretty aware about MiHIN, so I'm going to skip over that. But basically, we're the organization that is going to be routing the data inbound and outbound of where it needs to go. But also with this pilot, again, as I mentioned previously, Reading is located in Hillsdale County, as is Hillsdale Hospital. So on the right-hand side, you'll see where Hillsdale County is on your Michigan MiHIN map. But Hillsdale is a 65-bed facility that serves nearly 50,000 residents. And as part of their partnership with Reading, Reading delivers patients to the hospital and then also shares that information with MiHIN. More specifically, too, Hillsdale Hospital is a great participant in the statewide network. And then as part of this pilot, Hillsdale is also sending us discharge medication reconciliation CCDs after the patient is discharged from their facility, in which MiHIN routes the data outbound to members of the patient's care team, and then also will be routed outbound to Reading Emergency Unit. So I know that a little bit more information to come to on that. There are two phases to our EMS pilot. Phase one is what we just successfully finished. So as part of phase one, Reading Emergency Unit will be sending those ambulatory CCDs to Beyond Lucid Technologies. And that information is all encompassing, a little bit more to come on the content of that data. But Beyond Lucid Technologies will then forward the ambulatory CCD to MiHIN in a given predetermined standard that we've already established. MiHIN is creating that real-time active care relationship between the patient that is in transit to Hillsdale, but we're creating that real-time relationship between the patient and Reading Emergency Unit, as well as the patient and Hillsdale Hospital. So if you remember kind of what I said at the beginning, the active care relationship is the backbone as to how MiHIN routes data. If we don't have a relationship established between the patient and Reading or the patient and Hillsdale, we're not going to be able to route the data to those entities. So MiHIN uses that inbound data to create those real-time relationships in real time and then route the data outbound. And then lastly, once we create that real-time relationship, we're going to route the ambulatory CCD to Hillsdale Hospital to aid in providing additional detail prior to that patient's arrival to their hospital or ER. As part of phase two, we're going to continue everything that we're doing in phase one and then some, which I do have some more information later on as well. But key things and key milestones as part of phase two is that following the patient's discharge from Hillsdale Hospital, Hillsdale will send what we call that discharge medication reconciliation CCD to MiHIN. Using that real-time active care relationship that we established during phase one between the patient and Reading, MiHIN's going to route that discharge medication reconciliation CCD back to Reading Emergency Unit and any members of that patient's care team that are actively participating in receiving those discharge medication reconciliation CCDs from the hospitals. So Reading Emergency Unit, as well as future EMS agencies, will receive a subset of that full discharge medication reconciliation CCD summary. And I'll go into specifics about that in a little bit. Aside from MiHIN routing that CCD back to Reading Emergency Unit, MiHIN is also going to route the initial CCD that we received from Beyond Lucid Technologies. So now we're talking about Reading sending the CCD to Beyond Lucid Technologies and Beyond Lucid Technologies sending that to MiHIN. We are going to send that specific EMS ambulatory CCD to members of the patient's care team that will be actively participating in this use case in the future. So not only sharing data with all of the members of the patients on the receiving side, right? So the hospital, the patient's care team, giving them the heads up that, hey, Megan Gibbs, for example, is in transit to Hillsdale, but we're also closing that gap with reading and then future EMS agencies as well. So because I'm a visual person, and maybe some of you are as well, I wanted to break out the different phases in an actual data flow diagram. So reading emergency unit will send, again, what I call the ambulatory CCD to Beyond Lucid Technologies while that patient is in transport to Hillsdale Hospital. Beyond Lucid Technologies will forward that CCD to MiHIN, and then MiHIN will not only create that real-time relationship in real time with both reading and Hillsdale, but following that real-time, that establishment of the real-time relationship will route that CCD to Hillsdale Hospital. So again, that's all part of phase one, and this is all something, this phase is in production today, or what I'll call pre-production, and I'll expand on that a little bit. But this data exchange is currently happening. As part of phase two, Hillsdale Hospital or any future entity or hospital health system that is participating in this use case will send those discharge medication reconciliation CCDs to MiHIN. From there, MiHIN does that lookup on our back end that says, okay, which organizations, who's participating, how do they want to receive the data? And then we'll route that discharge medication reconciliation CCD back to the participating EMS agencies, as well as members of that patient's care team. So a little bit more information, like I said before, later on in the slides, but really wanting to focus on the content of those CCDs that come from the EMS agencies. When we were working through and setting this up and creating that sort of standard, I was able to see some of the summaries and was really impressed with the amount of data that was included in those summaries from the EMS agencies, specifically from reading emergency unit. I will be the first person to say that I am no expert in this area, and going into this, I wasn't sure what information would even be included in there, but it's amazing the amount of detail that is actually in those CCDs. Blew my mind. But there's three key elements that we want to focus on as being a part of the content of those CCDs from the EMS agencies, right? In this case, from reading. So first and foremost, more information about that patient. I hate to say this, but it's what's the status? Are they alive? Are they not, right? That's something we don't ever want to talk about, but we need to prep the ER staff prior to that patient's arrival to have that expectation is, what is the status of the patient in transit, right? So what is their pulse? What is the information on their pulse? What's their heart rate? What's their blood pressure? So all the information that comes from somebody taking your pulse and putting that the blood pressure cuff on you, that's tracked within the content of those CCDs. Also, key information about social determinants of health. Did the patient call 911 because they didn't take their diabetic medication, but it's known because they didn't take their medication because they have a known transport issue, right? That information is important so that the hospital staff can meet with the patient to say, let's get you some resources, let's get you some help to make sure that you do have transport to pick up your medication. So we can prevent future ER visits to the hospital due to your inability to pick up your medication, right? How can we provide social care services to the patients that need them? And then what's the mechanism of injury, right? Why is this individual being transported to the hospital? Did they break their arm? Did they break their leg? Did they fall and hit their head? If they fell and hit their head, what happened? Are they unconscious? Why are they unconscious, right? So including all of that clinical information about the initial event that resulted in the 911 call. And I think to kind of put it in perspective too, one of the ones that I was reading through was that an individual was borderline unconscious, and they drank too much at a party. And it was key information about all of the events that unfolded until then. What specifically did the individual consume alcohol wise? What was the response like when they were working with the EMS providers? Did they answer questions? Were they lucid, right? All of that key detail was included in that summary. And all that information is shared with Hillsdale Hospital, again, to prep for the patient's visit, to remove any miscommunication gaps, and then also so they know the status of like what's actually happening when the patient is going to enter through those ER doors. So when you start talking about closing the gap for the hospital, that's just the one component, right? But how do we close the gap on the EMS agency side? So as you've seen in the other slides, in MiHIN routing the discharge medication reconciliation CCDs back to reading emergency unit, we're only going to include a subset of information that is pertinent to what the EMS agencies need. And that's your patient demographics, their insurance, and then the diagnosis from when the patient was discharged. So with MiHIN routing that data in an automated and streamlined process, we're eliminating a lot of additional work for the EMS agency. So some of the key things that reading had actually reported to us that has or will help as part of phase 2 is a great deal of labor hours in attaining patient demographics and insurance information, which I hear this from everybody, right? I know most organizations say that when they have to pull medical records, it's not in a timely manner. And they sometimes get it fast and sometimes they have to wait the standard amount of time. So we're able to streamline the exchange of patient data in that time, and then also reduce the amount of time that they have to allocate for their resources to go find out what specific patient information. Furthermore, they're able to do a direct upload of patient care reports into the hospital system. So reading is able to tie into Hillsdale Hospital's EMR and exchange information that way. But the key thing here, and I think, that we would like to think we already solved, but we're still working to solve, is faxing. We want to eliminate as much manual labor involved as possible. So no faxing, no scanning. How can we make sure that all of that information is exchanged in an automated and technical way to, again, reduce the man hours of having to go out and find the data, and then making sure that the data is faxed into the system or routed where it needs to go. So some of the prerequisites for future participation and things to keep in mind is, again, we're working through phase 1, or we've completed phase 1. We're still doing some follow-up from that, and now working on phase 2, is broken down by each participating entity. So for the EMS agencies, and again, how MiHIN exchanges the data, we want to make sure that they are participating in the MiHIN network, but more specifically, that they are participating in our EMS use case. Additionally, MiHIN is in the process of migrating to our integrated technology platform, for those of you that are aware, or maybe not. But we do have standards for our new platform, and the standard for exchanging HL7 CCDAs is being able to send version 3 for US CDI compliance. With that, we also want to make sure that the agency is able to support either RESTful API, direct secure messaging. Future transport mechanisms are probably going to be available in the future once we complete our migration to our integrated technology platform. But we want to make sure that that entity is able to receive those discharge medication reconciliations, CCDs from MiHIN that are essentially sent from the hospitals. And then last but not least, we want to make sure that that EMS agency is able to connect to our technology vendor Beyond Lucid. And given their vast knowledge and work already being done in the space, I know that they're able to make that a seamless process for any EMS agency. For the hospitals, we want to, similar to the EMS agencies, make sure that they're participating in the statewide network, and then also participating in the EMS use case as well, to make sure that we're able to get those ambulatory CCDAs to them when the patient is being transported to their hospital. We also want to make sure that they are participating in sending those discharge medication reconciliation CCDs to MiHIN, so MiHIN can forward them back to the EMS agencies that do participate. And then last but not least, again, similar transport mechanism support capabilities is that they're able to not only send and receive the data from MiHIN. Same thing pretty much for the active care team members. So that traditionally speaking, your provider organizations, really kind of any individual that has an active care relationship with the patient, participating in the use case, participating in the network, able to support those specific transport mechanisms. But the key thing here is that we want to make sure that those organizations are reporting their active care relationship, patient rosters, patient files, attribution files, right? I think we've kind of heard it explained all different ways, but we want to know the patient population that is tied to that active care team to make sure that we're routing the necessary data that we need to as part of this data exchange. So I know I've seen some questions in the chat that might tie into this slide here. But for planning for the future, right? What's next? Can I participate today? When can I participate? So granted, and understanding that we have all the data flowing as part of phase one, there is some immediate next steps that we're working on, not only specific to phase one, but also phase two. So we're still in the building phase and testing and deploying phase two into production, right? So talking through some of those standards and really managing expectations with reading emergency unit to say, hey, here's a sample of what the CCD will look like. Here's where you can find the patient demographics, insurance, right? All that information. But then you start talking about specifics. When can reading emergency unit receive that CCD from MiHIN? What's the trigger at Hillsdale Hospital for when they send that CCD? Is it in real time? Is there a delay, right? So we're working through all that level of detail right now as well. Also, with our integrated technology platform migration, our current data exchange is built on our Rhapsody interface. Our Rhapsody interface is not going away, but we want to migrate this current data exchange to our new platform to fully utilize all of the future capabilities that we will have. We're also kind of in partnership with Reading and Beyond Lucid Technologies and Hillsdale, evaluating the content of the ambulatory CCDs that come through. So it's working with Hillsdale to say, what's working, what's not working? Have you been able to reduce communication gaps? Have you been able to enhance care coordination? What is your ER staff saying about receiving this data from the EMS agencies, right? How do we take that feedback back to both Beyond Lucid as well as Reading and fill any gaps that we need to? Are there any enhancement that we can make? Is the data coming through as expected? Did anybody have different expectations, right? So we want to make sure that we're polishing up phase one as much as possible so that when we do deploy this as an opportunity for other individuals to participate, it's beyond polished, right? I can address all of those questions that somebody might have about when the CCDs are triggered, the content, the usefulness. What are the EMS agencies saying? What are the hospitals saying, right? Because I think it's really important to hear what other individuals have to say about something. And if there's anything I know about society, I know that there are people who will jump right in and there are people who want to watch. They want to listen, right? So what is that other person saying? Can I ease your concerns that you have about maybe participating in this data exchange, or even tell you how awesome it is? And it's not just my perspective, but it's perspective from those individuals that are participating. Not only do we want to do that in phase one, but we also want to do that as part of phase two. So working specifically with Reading to say, okay, what kind of gaps did we fill after we shared the data? Do you have any idea of how many man hours you were able to save? How is this helping your EMS providers? And we want to put all that information together and then share it with everybody. So everyone is in the know of what people are saying and how the data is flowing. And then again, evaluating to see if there's any additional steps that we can take to just make it a little bit better each time. And then last but not least, a heavy emphasis on our onboarding documentation and our support documentation. So what is it that you need to know that are the prerequisites of being able to participate in this use case? It can be as high level as this is what it is. These are the transfer mechanisms that you have to support. But what are those additional details, like being able to support HL7 version 3 to be a US CDI compliant? And not only that, but and really kind of wanting to put together any sort of supporting material that says, we've gone through the onboarding a couple of times. Here are some key details to be aware of as part of this process, or maybe some questions that you need to ask your staff, or some things to think about, right? Especially if we find out that the hospitals don't trigger the CCDs in real time, what's the delay? Really trying again to fill any sort of gaps, but being able to manage expectations and make this data exchange as best as it possibly can be. So I think that was my last slide. Yep. So let's see here. Katie Lewis, I think we have some questions.
I unfortunately got booted again and it deletes all of the chats. So you're going to have to go back a little bit of the way.
Let's see.
Our last conversation was around the substance use disorders. So if you want to start from the comments from below that and work your way down.
Yeah. So I see John joined. John, great to have you here. John is from Beyond Lucid Technologies. Do you want to take a minute to address Mark's concerns about the SUD information, especially with your knowledge and expertise in this space?
Sure.
I don't want to put you on the spot, but I know you're an expert.
Well, I don't know about that, but I'm certainly happy to address the questions. And thank you for putting this together. Thank you for a really tremendous advocacy for the role of or the value of connecting mobile medicine to the rest of the healthcare ecosystem. We have been honored to partner with you guys in that effort. When you refer to Mark's question, I assume you're talking about the substance use one, because there were a couple other EMS related questions too.
Yes, that's correct. We can start with the substance abuse, and then I'll go through the list.
Sure. Yeah. No, 42 CFR Part 2, and the question of protection of the data. So in a 911 context, very simple, 911 context, those rules essentially don't apply. They do, but the 911 provision of care overrides the privacy protection. So HIPAA flows downhill. The Part 2 rules similarly. So in the 911 environment, you are allowed to share information from the ambulance with the next provider of care, no matter what. The substance use protections of Part 2 come in on the return of data. So the question needs to be parsed out a little bit. Certainly happy to address if there's any more specifics that Mark wants to share. But the systems that we have in place that you described so well, Megan, do accommodate for that because essentially the inbound data are they're hitting our system, as you mentioned. They're coming in from the ambulance service, and then they're hitting our system and being shared onward. At that point, there is a marker in the record as to, based on the data standard, as to whether this is a 911 call or a non-911 call. And so in a non-911 environment, for example, a follow-up with a patient or community paramedicine environment, someone's asked, someone's a frequent user of EMS resources. So the hospital or public health entity may have sent the ambulance service out to their home, or, some other context, maybe, they're in an alleyway where they're known to be encountered on a routine basis. If any of those records are not from a 911 triggered environment, then 42 CFR Part 2 provisions apply, and the authorization for sharing and revocation of data access must be documented. But if the patient is emergent, so if there was a 911 call for a patient who was suspected of overdose, for example, and an ambulance rolled out to respond to them, any of the data that they captured in that environment is shareable without question. And there is years worth of federal guidance that bolsters that position that certainly I'm happy to share, and the feds are happy to share. They have many, many times. So it's a pretty cut and dry question, and it really all comes down to whether it's a 911 call or not.
Thanks, John. Yeah. I also did just look on my side too really quickly. So that attestation form that I was speaking up before, that is a non-applicability of 42 CFR Part 2. So pretty much kind of all the things that John had mentioned. And we do send that attestation form to the EMS agencies for them to sign. But again, it highlights a lot of the key detail that John just explained that basically will allow the data exchange to happen. I was looking through the chat too, and John, I'm just going to keep you for one more moment here because I think you'll be best to answer this question too. So Samantha had asked, can you provide more detail on what happens to the EMS data, what it is once it is sent from reading emergency unit to Beyond Lucid to address the issues of standardization? So just a little bit more information of what that data exchange looks like between reading or any EMS agency at that point to Beyond Lucid Technologies.
Yeah, absolutely. So, and I also saw a question earlier in the chat about how much of this process is automated versus how much of it is manual. And I'll leave the portion on about the MiHIN side for you, Megan, if you want to address what if any portions on your side are manual. But on the EMS side, it's essentially all automated. So it's actually really exciting. The inbound data that we receive from the EMS agency conforms to a standard called the National EMS Information System, or NEMSIS. And NEMSIS has some overlaps with the HL7 data sets like USCDI, but it also has some data that are not in USCDI. So essentially what's happening is we're ingesting the NEMSIS data, and it is agnostic. So it doesn't matter what vendor is sending, as long as, and that's actually a really big deal in Michigan, because I believe at last count, there are 19 different EMS record systems. So they're called electronic patient care record systems, or EPCR systems. And there are more than a dozen of them in Michigan. But they all must conform to this federal standard, NEMSIS. So we receive those data and we ingest them, and then we convert them using a conversion engine that essentially maps over the data that exist in the CCD, and we repackage the file. So we take the data that do not exist in the CCD, for example, things having to do with out-of-hospital care that have no corollary in US CDI, information about vehicles, for example, motor vehicles, I mean, and so on and so forth. And we take the data that are conformant on the other side. So someone had asked about vitals beyond heart rate, for example. That includes all of those vitals. So respiratory rate, galvanized skin, sensitivities, mean arterial pressures, scales and scores, Glasgow Coma score, there's a wide range of data that map through. APGAR is another one for children. So all of these data that have a role in the US CDI core, in the CCD, and that exist in NEMSIS, and we essentially repackage the NEMSIS data in such a way that they are exported from our system as CCDs. And so that's what we're handing over to MiHIN, which MiHIN then ingests and does its magic. So I can attest that on the pre-hospital side, the out-of-hospital side, it is all automated. We essentially ingest exactly what an ambulance service would be sending to the state of Michigan for its compliance purposes, or to a billing service. So that does include PHI. It does include insurance payment information, if available. And again, as long as it has a role in the CCD export, that is what's flowing through on the other side. Does that more thoroughly answer your question than you'd probably like?
No, I appreciate it, John. I always appreciate the context too. And from the MiHIN side, it's all automated as well. I've seen before in our systems that as soon as the message comes through and we work to identify the members of that patient's care team, all the inner workings of saying that this specific data needs to go here, here, and here. I know that happens in 1 second, if not under a second. And then once you start talking about migrating all the capabilities here to our integrated technology platform, I anticipate it even to be even faster. The only thing that comes to mind in terms of what may or may not be manual here could potentially be on the hospital side. But keep in mind that I'm saying this with maybe my 2018 memory in mind. I know that years ago when I was working through some of the hospitals to get their CCDs to MiHIN, we found that there were limitations from the EMR vendor side. So there were a couple of vendors, Meditech is one that comes to mind, that I know at that time, they didn't have the ability to transmit those discharge medication reconciliation CCDs to MiHIN in real time. And it actually required a resource to sit at the computer and click the mouse to trigger the message to be sent. Now I say that again with 2018 knowledge. I'm not sure if that's still the capability today. I really don't think it is. But even as we progress forward from 2018 to now and continue to go forward, all what we're doing, we want to do it in an automated fashion and remove as much manual labor as possible, regardless if you're talking about a sending organization or a receiving organization.
If I can add one thing, just since you mentioned 2018 knowledge, can you guys hear me?
Yes.
Right. So I think it's something worth calling out that is very, very prideful to me about this collaboration with you guys. Interoperability has been a hot discussion and an area of pain for a lot of people for a long time. The number of organizations that have come together in this project to demonstrate interoperability in real time is just remarkable. And that includes, another EPCR company, right? So there's an EPCR company that is agreeing and is in fact sending data to us. There's us that are sending data to you. There's you that are sending data to the receiving points, right? So I'm just so proud, and I hope to the degree that again we look back on where we were and look at where we're going, and this is a demonstration that companies and organizations can work together very, very effectively. when they are asked to. That's really all it took. So I certainly want to congratulate and thank you, Megan, and your team, because this was really a remarkable example of someone like a hospital and an ambulance service coming to you guys and saying, how can we work together better? And we ended up partnering with others in our ecosystem on the EMS side in a way that was just very friendly. And I think it demonstrates that it's certainly possible when folks are oriented towards the mission.
Absolutely agree. Thanks, John. I know we only have a couple minutes here. So Susan, your question regarding reading, utilizing the discharge detail that is sent back to them. So we are not yet in production, I guess, per se, of routing the discharge medication reconciliation CCDs back to reading. We are about ready to test that, I think, in the next couple of days. And I know we have a meeting, I believe this week, even to manage expectations from that front. But I know that their plan is to use it for billing purposes, right, to close the loop, making sure that they have all the information that they need from the closure, I think, of the patient being discharged from the hospital as well. But absolutely more information to come. So that's kind of the follow-up of once the data is flowing in production, right? We want to give it a couple of weeks. We want to work out any sort of technical kinks that might be there, but then following up to say, how specifically are you incorporating this new data set into your workflow? Is it helping? Is it hurting? If it's helping, tell us how. If it's hurting, where can we make enhancements to make sure that it's streamlining the workflow processes on the organization side? Looking through, let's see here. Regarding Melinda's question of what information will be available to the PCP office. So everything that John had just mentioned about the content that will be available in those ambulatory CCDs that reading sends to Beyond Lucid forwards to MiHIN. So as part of phase 2, we'll be able to route that information to the members of the patient's care team, so long as they're participating in the use case. And then if those members of the patient's care team are also participating in receiving the discharge medication reconciliation CCDs from the hospitals, they'll be able to get that discharge summary of care from the patient's visit. So one of the things that we're working on and incorporating into the onboarding process of this use case is that for those receiving entities like your provider organizations, great, we understand that you want to participate in the EMS use case. Let's also confirm if you are participating in receiving the discharge medication reconciliation CCDs. And if not, let's incorporate that into your request so we can make sure that you're not only getting the summary of care from the patient being transported to the hospital, but then also when the patient was discharged from the hospital as well. I believe, yes, absolutely. We'll share a copy of the slides. I will put my email in the chat for everyone. Please feel free to email me. You can call me, get a hold of your account manager if you want to redirect any questions to me. Happy to meet and share any additional information that I have. But thank you so much again for taking time out of your Monday and meeting with us today. I don't know if there's any additional questions or any sort of context that Katie wants to share. But I hope you all have an excellent work week this week and a happy early October.
I'm gonna say that about sums it up, Megan. Thank you so much. And Jonathan for jumping in as well. Megan did put her information in the chat. It's just her name, megan.gibbs@mihin.org. Nice and easy to remember. We will post all of the slides and the recording on our website, like we do with all of these downloads. So you can always go back and reference any of the downloads that you might have missed or that you joined and want to go back through. And if you have any other questions, feel free to reach out to myself, Megan, Joanne, your account reps. Anyone here at MiHIN is always happy to meet. Apologies that I'm not on camera. Zoom just was not my friend today. If anybody is a Lions fan, go Lions tonight and have a great rest of your week.
Thanks, everyone.